So hepatitis refers to inflammation or irritation of the liver, and there are lots of different causes of hepatitis. I guess in Western society the main cause would be alcohol, so alcoholic hepatitis causing liver damage. But on a global basis, the main cause of liver inflammation and liver damage is actually viral infection of the liver. And there are a number of different hepatitis viruses, and conveniently they're called hepatitis A, B, C, D and E. Even though there are other viruses which can irritate the liver, these are the main hepatitis viruses. Now, the symptoms of hepatitis depend upon whether you have an acute hepatitis or whether it's a chronic hepatitis. And by acute hepatitis, I mean that the person or the patient has acquired the infection quite recently. And under those circumstances, there is frequently associated an illness where patients develop nausea and sometimes vomiting and diarrhea. And then the telltale sign that it's a hepatitis which is causing their problems is the development of jaundice or a yellow discoloration. So that would be a typical course of an acute hepatitis. So it's recently acquired and the patient becomes jaundiced within weeks or months of that. Probably more important on a global basis is the chronic hepatitis. So this involves a patient acquiring the infection, so they may have a syndrome like an acute hepatitis, but instead of completely resolving and eliminating the virus from the system, the person can become a carrier of the infection. And when they're a carrier of infection, then you can end up with a chronic irritation of the liver. And over a period of decades usually, and frequently without any symptoms during that long period, you can have established chronic liver damage, which leads to scarring and eventually to a cirrhosis of the liver and sometimes to liver cancer. So 5 main hepatitis viruses. All of them can cause an acute hepatitis. 3 of them can cause a chronic hepatitis with a carrier state going on to cirrhosis, liver failure and liver cancer. Frequently you have symptoms with acute hepatitis, but with chronic hepatitis there's usually an absence of symptoms until the liver damage is really quite established.
And who can get viral hepatitis?
So anybody can get viral hepatitis, of course, unless they've been vaccinated against the specific viruses. But in answering that question, it's probably best to look at the 5 different hepatitis viruses and the way that they're transmitted. So hepatitis A and hepatitis E viruses are very similar. They're both what we call fecal-oral transmission, which basically means that you've managed somehow to ingest somebody else's feces. Now that's usually by contamination of the water supply, of course. And hepatitis A and E are viruses which will cause an acute hepatitis, so within weeks of being infected you'll get the symptoms that I spoke about with the stomach upset and then eventually jaundice. And then in 99.9% of cases the infection is completely eliminated. So people have immunity to infection, and subsequent infection with the same virus is most unlikely, certainly for hepatitis A. So that's hepatitis A and D, and that's an infection usually acquired in countries that have substandard or standards of sanitation which are lower than you would expect in North America or Western Europe, for instance. And travellers are quite susceptible then to that. Travellers from Western Europe going to the Indian subcontinent, for instance, or to Africa are quite high risk for coming into contact with hepatitis A and E viruses, and therefore they're susceptible to that. Now, hepatitis B virus has a different epidemiology, and globally most people who've got hepatitis B virus have acquired the infection from their mother. So if mum is a carrier of hepatitis B virus, then unless the baby gets vaccinated at birth, then most infants will end up being infected by hepatitis B virus. They'll get it from their mother. And if they catch the infection at the time of birth from their mother, then it's extremely likely that they'll become lifelong carriers. And of course, if they're female children, they'll end up mothers themselves, and it will be transmitted down from generation to generation. So hepatitis B, we call that vertical transmission, I should say, when it's from mother to infant. With vaccination of the neonate, then the infection of the baby can be avoided. So globally, there are major vaccination programs which are trying to interrupt that cycle which has gone on for generations. In Western society, the main way that you come into contact with hepatitis B is via sexual transmission. I think that's often forgotten, that hepatitis infection, particularly hepatitis B virus infection, in adults is principally sexually transmitted. It can be transmitted in other ways, for instance, by injecting drug use. So it's common to find that long-term injectors have come into contact with hepatitis B that way. Blood transfusion historically was a cause of hepatitis B infection, but no longer, because the blood supply, at least in Western society, is quite safe now and screened for hepatitis B. So to summarise then, the hepatitis B transmission in countries that have a very high prevalence, the infection has usually been from mother to child, or between children, within the family or at preschool. In Western society, infection's usually acquired as an adult, and it's most often a sexually transmitted infection. Which leaves hepatitis C virus. Now, hepatitis C virus, again, is quite different from the others in terms of transmission and who's at risk. If you've got hepatitis C virus, then usually you've got somebody else's blood directly into your own bloodstream. So in Western society, that means that most often that you've injected drugs and shared needles, or shared the paraphernalia that goes with drug injection. So again, in Western society, the most common way of acquiring hepatitis C would be as an adult, because that's when injecting drug use usually starts. And the trouble with hepatitis C infection is that it's frequently completely asymptomatic in the acute stage, so that people may not be aware that they've been infected with the virus. The other trouble is with hepatitis C is that the outcome is nearly always chronicity, so that spontaneous clearance of the virus by the immune system is really most uncommon. And hepatitis C then infects a person, they become a carrier, and of course they become a potential source for infecting other people without even knowing that they're a carrier themselves. Now, the other ways that you can get blood into your own bloodstream would include blood transfusion, of course, but that's again quite uncommon in Western society. In fact, it's exceedingly rare now because we can screen blood products for hepatitis C, and also because concentrates like factor VIII that might be given to people with haemophilia are now recombinant factors, so that there's no risk of human transmission by virus. And that probably leaves, no, hepatitis C, I should say, it can be transmitted sexually, but that's really quite uncommon. So if you have a stable monogamous relationship over many decades, then you frequently find that the spouse has not been infected, even if one of the couple is a hepatitis C carrier. So sexual transmission of hepatitis C is rare in comparison with hepatitis B, where sexual transmission is common. The exception to that, and an emerging problem, is that amongst MSMs, men who have sex with men, where more vigorous sexual activity is associated with a much higher risk of blood getting from one person's bloodstream into the other through mucosal damage and trauma usually. So there is an emerging problem of hepatitis C in the gay community, and that's something that needs to be dealt with. Now the final of the 5 viruses which I didn't mention is hepatitis D virus. And hepatitis D virus is an unusual virus. It's a defective virus in some ways because it can only infect people who are already infected or simultaneously infected with hepatitis B virus. It probably affects about 10% of hepatitis B carriers in the UK and figure not much greater than that across Europe. But in some parts of the world it's very prevalent, Central Africa and some parts of Eastern Europe. And the characteristic of hepatitis D virus infection is the severity of the damage that it does to the liver. It tends to damage the liver very quickly, so that instead of taking 3 or 4 decades to go from infection to cirrhosis, you often see that process condensed into 10 to 20 years, for instance. The hepatitis D transmission then historically has been transmitted in the same way as hepatitis B because the 2 viruses have tended to travel together. So that's a summary of who gets hepatitis virus infection.
And do we know how these viruses damage the liver?
So the viruses themselves are probably in general not directly cytopathic, and by that I mean that you can have large amounts of the virus in a cell, in the hepatocyte or liver cell, without that liver cell being damaged in any way, so that the function and the integrity of the liver cell can be preserved even with very high levels of virus within it. And the best example of that is probably the young person who's become a carrier of hepatitis B virus, because the cells, the liver cells, can be producing masses of virus. It means that a large proportion of the cellular machinery must have been diverted into virus production. But despite that, and particularly in these young patients with high levels of virus, you see no evidence of impairment of liver function. And in fact, if you look at the liver under a microscope, it looks remarkably normal. So it's not the presence of the virus which actually causes the damage in general. It's the body's response to the damage which is the key component in causation of liver injury. And what the immune system, what everybody's immune system is designed to do is to identify and to discriminate and to eliminate foreign proteins, so that when a cell, a liver cell in this case, is infected with hepatitis virus, then some of the viral proteins should eventually make their way to the surface of that cell and be exposed to the exterior, so that the immune system can come along and have a sniff and decide whether there's any foreign proteins in the cell. And if the immune system comes along and detects a viral protein and recognises that as being a foreign protein, then a sequence of events should follow where the immune system leads to the destruction of the infected hepatocyte. So it's actually designed to eliminate the factories of the virus. And that's a key component in elimination of the infection. There are other ways, other aspects of the immune response which are important as well. But the key thing is that the hepatitis and the liver damage are due to the immune system's recognition of an infected cell and then the elimination of that cell. So if you look down a microscope, you see that the liver cell plate is infiltrated by lymphocytes. And the purpose of those lymphocytes is to recognise and then to program the destruction of those liver cells. So that's what causes hepatitis. The hepatitis is the inflammation, and the damage is not directly cytopathic, it's usually immune mediated.
What should one do if they think they may have viral hepatitis?
Okay, so with our knowledge of the epidemiology of infection, then there are people who may have reason to believe that they're at risk of being a carrier of hepatitis. So here I think we're talking mainly about well people who have put themselves at risk in some way, or have been at risk in some way, and therefore are keen to find out whether they might be a carrier. Now, in some parts of the world, the prevalence of hepatitis carriage is so high that just being a member of that population is sufficient to encourage you to be tested. For instance, if we look at the first generation Pakistani community in England, then we know that the prevalence of hepatitis carriage in that community is the same as the prevalence in their country of origin, in their region of origin. So that we've got a good idea then that there's about a 1 in 20 chance that a British first generation Pakistani would be a carrier of hepatitis, a 1 in 20 chance. So that's a sufficient risk that person should consider getting themselves tested. We know that first generation Chinese migrants have a very high prevalence of chronic hepatitis B infection. So the prevalence of hepatitis B carriage in China is 10%. We shouldn't be surprised that every time we look in any other country at the Chinese community, we find a hepatitis B prevalence of 10%. So again, just being a member of an ethnic group from a country where prevalence is high should be sufficient for people to want to be tested for hepatitis carriage. If you've ever injected drugs in the past, then you should seriously consider getting yourself tested for hepatitis C infection. And there are public health campaigns all over the world which are encouraging people who may have a history, often 30 years ago and often briefly, but if they've got any history of hepatitis, of injecting drug use, then hepatitis C infection is a distinct possibility and they should get themselves tested. In North America, for instance, the baby boomer population is being targeted now. So people born in the US between 1945 and 1965 who during the 70s and 80s may have come into contact with hepatitis C, often through injecting drug use. And also that was a period before there was screening of blood products. Therefore this cohort are being targeted as a group that might have a high prevalence of hepatitis C infection without knowing that they've got it. The importance of testing them is that if they were infected in the 70s and 80s, and we know that it takes 30 years until people have serious liver damage, then this is a group which are now knocking on the door of cirrhosis or possibly have established cirrhosis, severe damage to the liver, without yet knowing about it. And the treatments are so good for chronic hepatitis now that it's important that people are diagnosed at a pre-symptomatic stage, even if they've got serious liver damage, because death from liver disease can be prevented with good antiviral therapy. Did we cover that?
I'd ask a separate question on that now, so we can use it for the next week.
Yeah.
Yeah, so we're moving on to the next section.
I'm just going to do that final question separately.
Okay.
Then I'll leave a few seconds gap, and then we can ask what is liver fibrosis independently cirrhosis.
Yeah. Okay.
I'll just leave it on. You ready to leave a few seconds of silence?
What are the current treatment options for viral hepatitis?
So we've discussed acute hepatitis and chronic hepatitis. Acute hepatitis in general requires no antiviral therapy. So the majority of people who get acute hepatitis will find they have a self-limiting and resolving illness. So antivirals are not used in that setting. We usually just observe the patient to make sure that the liver damage does not get so severe and anticipate recovery in the majority. So the treatment of viral hepatitis is really targeted towards people who are carriers of the infection. Remember, it's carriers that have the chronic liver damage, and it's the chronic liver damage that goes on to cirrhosis, liver failure and liver cancer. The reason to treat the chronic hepatitis, and here we're talking about hepatitis B and hepatitis C infection, is that if you can eliminate the virus or suppress the virus effectively and indefinitely, then you prevent further liver damage. So there's a large body of evidence now that in the same way that treatment of HIV infection by permanent suppression leads to recovery of the target organ. In HIV, of course, it's the lymphocytes that recover. But in chronic hepatitis, if you suppress or eliminate infection, then we can see the hepatocytes start to recover. So we stop liver disease progression, and then over a relatively short period of time, if we measure it, we can find improving liver function and even a reversal of the scarring and fibrosis which has been developing over the entire duration of infection up until that. Now for hepatitis B, the paradigm is very much that of HIV treatment, in that our antivirals that we use are very good at suppressing but not very good at eliminating infection. So for the large majority of patients treated for hepatitis B, we aim to suppress the virus to undetectable levels, and having done that, we're confident that disease progression is prevented and that recovery will start to occur. We even think that cirrhosis, which was previously thought to be an irreversible state, can reverse to a pre-cirrhotic or non-cirrhotic condition with sustained inhibition of the virus replication. The treatment paradigm for hepatitis C is completely different from hepatitis B and from HIV, because it's a short duration of therapy which aims to completely eliminate infection. And if you completely eliminate infection, then we see that same sequence of events. We prevent progression, we start to see a regression of liver damage, and we can be confident that the person that we've treated will not suffer consequences of cirrhosis like liver failure in the future. Now the hepatitis C treatment presently is being revolutionised because we're going through a period where there's been very active drug development, and the drugs are incredibly effective against hepatitis C, and some of them have been licensed quite recently in many countries around the world, and the real challenge now is to make sure that the additional drugs come through and that we can afford to treat patients with these antivirals. That's going to be one of the major challenges, I think, during the next 5 to 10 years. Affordability rather than efficacy.